Bismillahirrahmanirrahim. This is part 3 of antidiabetic drugs. Part we have discussed insulin. Insulin which is given to patients that are of type 1 diabetes mellitus. Now we are going to discuss oral hypoglycemic drugs that are usually used in type 2 diabetes mellitus. Though first of all, number 1 are the agents that bind to sulfonylurea receptor and stimulate insulin secretion. These agents are sulfonylureas, meglitinides, and D-phenylalanine derivatives. The number 2 class of oral hypoglycemic drug is the agents that lower glucose level by acting on liver, muscle, adipose tissue, and these include two classes of drugs, Biguanides and thiazolidine-diones. Number 3 are the agents that lower intestinal absorption of glucose, and these agents are called alpha glucosidase inhibitors. Number 4 classification of agent is that mimic incretin effect, and these agents are called GLP-1 receptor agonist. And number 2 dipeptidyl peptidase inhibitor, that are DPP4 inhibitors. On number 5 are the agents that inhibit reabsorption of glucose in the kidneys. These agents are called glucose co-transporter inhibitors, also named SGLTs. On number 6, there are the agents that act by ill-defined mechanisms, in which are the drugs pramlintide, bromocriptine, and colesevelam. This was the classification of the drugs. Now we are going to discuss one by one. Here is a picture in which you can see the site of action of different classes of antidiabetic drugs that act and decrease the blood glucose level. You can see thiazolidine-diones act on muscle and adipose tissue, while alpha glucosidase inhibitors act on your intestinal tract, while insulin secretagogues act on the pancreas. Similarly, DPP4 inhibitors also act on pancreas, and they increase the insulin secretion from the functioning beta cells of Langerhans. All of these agents lead to decrease in the blood glucose level. Similarly, biguanides act on the liver and they cause decrease in the blood glucose level. This is for your remembrance, where the site of action of different antihypoglycemic drugs. Now we are going to discuss them one by one. There are 5 classes of the drugs that are used to treat type 2 diabetes mellitus. First of all, the sulfonylureas. They act on sulfonylurea receptors. These are the oldest agents that are being used for the treatment of type 2 diabetes mellitus. They increase the release of insulin from the functioning beta cells of Langerhans. Number 2, they also decrease the production of glucose in the liver. Number 3, they increase the number of insulin receptors. And number 4, they increase the peripheral use of glucose. It means that whenever you are asked to produce mechanism of action of sulfonylureas, how they decrease the blood glucose level, you should produce all these 4 effects. So they are effective only if there are functioning beta cells of Langerhans. Their primary side effect is hypoglycemia. Almost all the oral antidiabetic drugs, the primary side effect is hypoglycemia. However, there are certain euglycemic agents. I will tell you as we will proceed. They bind to the receptor that is called sulfonylurea receptor, and in this way they inhibit the efflux of potassium ion. As a result, there will be depolarization. This depolarization leads to voltage gated calcium channels to open. There will be calcium influx and there will be release of preformed insulin. This is the mechanism of action, how the sulfonylurea causes release of insulin from the functioning beta cells. Here is the diagram. It is a very good diagram. I have asked you that the stimulation of the alpha adrenergic receptors increase the release of insulin. You can see here, you can see this is the alpha adrenergic receptors. These are inhibitory in nature. Therefore, they will act on adenylyl cyclase. This adenylyl cyclase will lead to production of cyclic AMP and then protein kinase A, and this protein kinase A will cause release of insulin rich secretory granules to release insulin. Similarly, this is the sulfonylurea drugs that act on sulfonylurea receptor, and this sulfonylurea they cause efflux of potassium that leads to depolarization, that leads to opening of the voltage gated calcium channels. There will be entry of calcium, and this calcium causes the release of insulin from the preformed insulin secretory granules. Similarly, I have told you that oral glucose is a very good stimulus for the release of insulin. Here is the glucose. When it enters the cells, there is production of certain metabolites that causes the production of ATP, and as a result, for this production of ATP, there will be potassium efflux that leads to depolarization and opening of the voltage gated calcium channels that causes the release of insulin. So oral glucose are the basically good stimulus for the release of your insulin, and here is the mechanism of action. Similarly, same is the with free fatty acids. Similarly, amino acids, all these causes release of insulin secretion. You can say it is basically a beta cell. There are two types of generation of sulfonylureas. First generation are not used nowadays. The drugs were tolbutamide and tolasamide. Nowadays we use second generation agents, and these are glipizide, glyburide, and glimepiride. These drugs may be used along with other antidiabetic drugs like metformin, glitazones, insulin, or acarbose. The next group of class is D-phenylalanine derivatives. The drug name is Meglitinide. They act on sulfonylurea receptor, and they cause the closure of the potassium channel that will lead to depolarization, and this depolarization will cause opening of the voltage gated calcium channels, and there will be inward entry of calcium, and this calcium will cause release of preformed insulin. They usually they do act within 20 minutes, and their half-life is about 1 hour, and they are very helpful in reducing postprandial rise in glucose, that is the glucose that rise after eating. Now is the meglitinide analogs. The drug name is repaglinide. They are sulfonylureas. They lower the blood glucose level by stimulating pancreatic secretion of insulin. They are used in monotherapy or in combination with metformin. They should be taken just before a meal. Dosage and frequency is flexible depending upon the food intake. Meglitinide have the similar effects. There are two drugs in this meglitinide analogs, repaglinide and metiglinide. These have same effects. The next group of class is alpha glucosidase inhibitors. The drug names are acarbose, meglitol, voglibose. They inhibit alpha glucosidase enzyme. These enzymes are present in our gastrointestinal tract. So they delays the absorption of complex carbohydrates and simple sugars, because these enzymes are needed for the breakdown of complex carbohydrates into simple sugars, and these simple sugars are then absorbed into the blood. And when we give alpha glucosidase inhibitors, these enzymes are inhibited, So there will be no breakdown or delayed absorption of these complex carbohydrates and simple sugars, and these simple sugars will not be absorbed in the blood, and so the blood level of glucose will decrease. Similarly, they can be combined with insulin or with other sulfonylurea depending upon the patient condition. They are contraindicated in cirrhosis, in malabsorption, and in severe renal impairment. They are usually taken at the beginning of each meal. The most common side effect with these alpha glucosidase inhibitor is bloating and diarrhea. But the point is that they usually tend to diminish with ongoing use because of chronic exposure to carbohydrate induces the expression of alpha glucosidase in jejunum and ileum. Usually hypoglycemia with alpha glucosidase inhibitors do not occur if they are used alone, but it can occur if we are using these drugs with other antidiabetic drugs. So if it occurs, then hypoglycemia should be treated with glucose, that is with dextrose, not sucrose, because this glucose or dextrose is not inhibited by the alpha glucosidase inhibitors. Next group of class is Biguanides. And I have told you that there is one such class that does not cause hypoglycemia. So these biguanides are called euglycemic agents because they do not cause hypoglycemia. They activate AMP activated protein kinase. The drug name is metformin. The metformin increases the use of glucose by the muscle and the fat cells. Number 2, it decreases the hepatic glucose production, and number 3, it decreases the intestinal absorption of glucose. So by these three mechanisms, metformin decrease the blood glucose level. I'm again repeating, they does not cause hypoglycemia, and as with other drugs, they can be used alone or in combination with other drugs. They are contraindicated in liver and renal impairment, and they can result in lactic acidosis if they are used in patients of renal impairment. So, renal function should be assessed before starting of this medication. Similarly, caution should be taken with parenteral radiographic contrast media that contains iodine because it may cause renal failure and has been associated with lactic acidosis. It is the first line therapy usually in obese patients that are of type 2 diabetes mellitus. These drugs that are biguanides decrease the macrovascular and microvascular morbidity. They are also used in the prevention of type 2 diabetes. They are the drug of choice in obese, middle-aged patients that have fasting hyperglycemia. Here is a picture. You can see how metformin acts. So first of all, metformin acts on liver and it causes decrease in gluconeogenesis, glycogenolysis, and decrease fatty acid oxidation that leads to decreased blood glucose level. By acting on the skeletal muscle, it increases the insulin mediated glucose uptake, it increases the glycogenesis, and it decreases the fatty acid oxidation. All these three effects will decrease the hyperglycemia. And by acting on the intestine, it increases the anaerobic glucose metabolism that leads to decrease in the hyperglycemia. So that is why metformin decreases the blood glucose level by acting on skeletal muscle, liver, and intestine. Because of this anaerobic metabolism, the metformin in patients with liver impairment and renal impairment can cause lactic acidosis. Next group of classes, glitazones. The drug names are pioglitazone and rosiglitazones. They are called TZDs or thiazolidine diones. and they are insulin sensitizers. Why they are called insulin sensitizers? Because they decrease the insulin resistance. I have told you that in type 2 diabetes mellitus there are two types of problems. Number one problem is that there is decrease release of, there is deficiency of insulin in the body. Number two problem in type 2 diabetes mellitus is that the insulin is present but the receptors are resistant. Receptors does not allow the present insulin to work properly. So this is called insulin resistance. So these glitazones decrease the insulin resistance. They stimulate the receptors on the muscle, fat and the liver cells. You know that insulin receptors are present on muscle, fat and the liver cells. So glitazones stimulate these receptors to the action of present insulin. So this results in increased uptake of glucose in the periphery and decreased production of glucose by the liver. So they are going to decrease the blood glucose level. They are insulin sensitizers. You may be asked question, write down the names of the drugs which are insulin sensitizers. So glitazones, you will. They are contraindicated in patients with liver disease or who have ALT levels of more than 2.5 of normal. They may be used as monotherapy or in combination. In heart patients should be used cautiously, and always before starting of glitazones, baseline LFTs should be performed. Mechanism of action, they act on PPAR gamma receptors. They are ligands of peroxisome proliferator activated receptor gamma, also called PPAR gamma. Basically, it is a steroid and thyroid superfamily of nuclear receptors, and these receptors are involved in lipid and glucose metabolism and insulin signal transduction. Glutazones have been causing bladder cancer, so it has been banned. And rosiglutazones cause myocardial infarction, chronic heart failure, and stroke and death, so it also have been withdrawn. I have already told you they reverse the insulin resistance, and they also are euglycemics. First class of drug that was euglycemic, that were Biguanides, metformin, and the second class is thiazolidinediones. They are also euglycemic. They are absorbed within 2 hours of ingestion. They are metabolized in the liver, so should be used cautiously in the liver impairment and renal impairment. They usually cause weight gain because of adipocyte differentiation. So the patients may gain weight, and similarly edema, headache, myalgia and mild anemia. In older females, there is a problem that they may experience fractures. In this diagram, you can see how these PPAR gamma agonists are PZDs are thiazolidinediones act. They act on the adipose tissue. They are going to increase the adipogenesis, increase fatty acid uptake, increase lipogenesis, increase glucose uptake, and decrease tumor necrotic factor alpha and adiponectin. All these factors decrease the plasma free fatty acids, so they reset the glucose fatty acid cycle that decreases the hyperglycemia. And because of this adipogenesis, patient experiences weight gain. And because of all these effects that it produces on adipose tissue, insulin resistance decreases. When they act on the muscles, they increase the glucose uptake. So in the blood, glucose will decrease. That will lead to decrease in hyperglycemia. When they act on the liver, they causes decrease gluconeogenesis. So they are going to decrease the insulin resistance. They are insulin sensitizers. So they, by acting on the adipose tissue, by acting on the liver and by acting on the muscle, they decrease the blood glucose level. This is again same TZDs, hot EZDs decreases the blood glucose level. Next class of drug is sodium glucose co-transporter inhibitors. This sodium glucose co-transporter is normally present in our kidney and it is responsible for most renal glucose absorption in the kidney. There are two transporters, SGLT1 and SGLT2, but the SGLT2 is mainly responsible for most renal glucose reabsorption. So they reduce the absorption of glucose in the kidney, so they will reduce the blood sugar. The urine test for these patients that are using these inhibitors, that are SGLT2 inhibitors, will be positive because of this medication. Their effectiveness depends upon the kidney function. If a patient's kidneys are impaired, you cannot use these SGLT2 inhibitors. There is a risk of genital infections and urinary tract infection in the patients who are using SGLT2 inhibitors. Why? Simple is the answer. Because they are increasing the absorption of glucose. So more glucose is present in the urine. So your genital infections and in the presence of more glucose, there will be more genital infections and more urinary tract infections. You can see here there are two transporters. In segment 3 of proximal tubule, there is transporter 1 and in segment 1 there is transporter 2. So basically the transporter 2 is responsible for the glucose reabsorption. That is why we use sodium glucose transporter 2 inhibitors for the for hyperglycemia purpose. So they will absorb the glucose and the more glucose will be excreted out of the body. This is the diagram that is showing the effect of different drugs. The bigger arrow, that is, this is the major effect and this is the minor effect. So you can see with thiazolidinediones, the major effect is of increased peripheral glucose uptake, and the major effect of alpha glucosidase inhibitor is the decreased glucose absorption from the intestinal tract. Similarly, with biguanides, the major effect is on liver, that is decreased hepatic glucose output, and the minor effect of biguanide is increased peripheral glucose uptake. With sulfonylureas and meglitinides, they increase the insulin secretion from the functioning beta cells. Similarly, with thiazolidinediones, the major effect is to increase the peripheral glucose effect and the minor effect is to decrease the hepatic glucose output. There is another drug that is called GLP-1 receptor agonist. This is exenatide and it is injected subcutaneously within 60 minutes before a meal. So insulin is an injectable drug and the second injectable is GLP-1 receptor agonist. If you are asked and list the drugs which are injectable antidiabetic, so you can say insulin and number 2 GLP-1 receptor agonist. They are absorbed equally from the arm, abdomen and the thigh, and their plasma half-life is about 2 hours and the duration of action is about up to 10 hours. They are excreted mainly by the kidney. There are two types of drug, exenatide and liraglutide. Liraglutide have longer action. Plasma half-life is more than that of exenatide. Another drug is dipeptidyl peptidase 4 inhibitors. And these drugs are sitagliptin, saxagliptin and linagliptin. These drugs increase the circulating levels of GLP-1 and GIP. What are these? I have told you that these are the normal hormones that are being secreted by your intestinal tract and they potentiate the effect of insulin. They increase the release of insulin from the preformed insulin vesicles. Their half-life is about 1 to 4 hours and they are metabolized in the liver and excreted in the kidney. The major side effects are nasopharyngitis, upper respiratory tract infection, headache and hypoglycemia. And they are used as an adjunctive therapy in type 2 diabetics who have failed to achieve glycemic goal. This is the mechanism of action of DPP4 inhibitors. So DPP4 inhibitors block the DPP4 and decrease the glucose. DPP4 enzyme inactivates GLP-1. So there will be incretin and GLP-1. So more. When this enzyme inhibit, there will be more GLP-1 and incretin. These GLP-1 and incretin stimulate the insulin release and inhibits the glucagon release. And both of these effects lower the blood glucose level. I am again repeating, these are DPP4 inhibitors. Normally DPP4 enzyme inactivate the GLP-1. These GLP-1 is normally present in our intestinal tract whenever we eat food or glucose. When this enzyme is inhibited, GLP-1 will be more available in the intestinal tract. So it will cause stimulate the insulin release, inhibit the glucagon release, that will lead to lowering of the blood glucose level. The next group of class is amino analogs, and the drug name is pramlintide. These are synthetic antihyperglycemic drugs. They suppress the glucagon release via undetermined mechanism. They delays the gastric emptying and has central nervous mediated anorectic effect. And they are also injectable. So there are three types of injectable drugs. Number one, insulin. Number two, I have told you. And number three are the pramlintide. And their plasma half-life is about 50 minutes. They are injected subcutaneously prior to the meals. And their side effects, obviously hypoglycemia and the gastrointestinal symptoms including nausea, vomiting, and anorexia.